Hi friends, good evening. I'm Dr. Ashutosh Gupta and I'm a consultant fetal medicine. So let us now talk about the echogenic kidneys, right? So how do you see, how do you identify, how do you make a diagnosis and what to do with those echogenic kidneys, right? So I have lived and have followed these echogenic kidneys for the last 10 years, right? I have published a lot of papers. So starting from the antenatal ADPKD, which is called as an autosomal dominant polycystic kidneys, to ARPKDs, to autosomal recessive polycystic kidney disease, to multicystic kidney disease, to mesangial sclerosis, to ambiguous genitalia. So I do have a lot of papers and all those stuff. But ultimately, the thing is this, that probably we never have had any objective sort of an parameter so as to quantify or so as to objectify or so as to prognosticate the renal functionings of the renal functioning or the functioning of the fetal kidneys, right? Pehla. Dusra, we have had a lot of cases in which we had a posterior urethral valve. So posterior urethral valve can be divided into three types. So we are not getting into the detail how do we look around for all these things. But now when we are having a complete posterior urethral valve, so what happens is this: the bladder, the kidneys are functioning, they're filtering the blood, the urine is being formed, but the urine is being collected in the urinary bladder, and then you see that the outside oligohydramnios or anhydramnios is being happening, and then the whole of the abdomen of the baby is being filled up with that bladder, right? So before doing those vesicoamniotic shunting, now it has been an established norm that you do the vesicosynthesis, meaning thereby कि आप उस bladder को tap करिए और जो fetal urine जो है उसको निकाल के उसकी biochemistry करिए, right? So meaning thereby हम kidney की जो functioning है उसका अंदाज जो fetal urine जो है उसकी biochemistry से भी लगा सकते हैं. So meaning thereby that we do have those established nomograms so as to see for sodium chloride osmolality and beta 2 microglobulin, right? These parameters they can be checked in the fetal urine by doing the vesicosynthesis, right? अब उसमें भी ये कहानी ये होती है कि that probably you wait or then that is the last ditch effort that probably you can do when the bladder is so full and therefore you are having surrounding the baby के आसपास पानी नहीं है और anhydramnios और oligohydramnios है and then we are dealing with a luto या lower urinary tract obstruction and we are having a big huge bladder, right? You getting my point? Now what happens is this ki of late we are now encountering a lot of echogenic kidneys, right? Now the thing is this. Now the thing is this that all these things they are being diagnosed as something around 20 weeks, and then we say that this could be part of the normal continuum, and the cortical differentiation can be there. So I do have had one paper published in which we've identified that antenatally, even though the kidneys were present, but the corticometal differentiation or the CMD was absent. And then we identified, even though we never did the a genetic study of that fetus, but then we've identified that the kidneys were failing, and we've explained and we've established that the kidneys were failing in the postnatal period, right? So that is an entirely different issue. Now, how do you see these echogenic kidneys? Right? So when the echogenic kidneys are there, so at 20 weeks it is there. So you buy some more time and then you evaluate the baby again after 2 weeks. So meaning thereby that from 20 to 22 weeks has already gone. And then if you decide on doing the amniocentesis, then that exomes or the genetic study would take something around 3 weeks. So meaning thereby that our deadline of taking an irreversible call with the pregnancy is almost at our neck or probably we have surpassed that particular time, right? Okay. So what to do when we are identifying an echogenic kidneys? Now how do you objectify, how do you prognosticate, what is the objective parameter or the test that we can do so as to identify what is happening with my kidneys, as a matter of fact. Okay, so there are one case in which we will explain what we have done and then how it has helped us to reach to a conclusion and what is the evidence which is suggestive of all these things. So this is what we are doing is the anomaly scan at 19 weeks and then we are being stuck with this ecogenic kidneys. Okay, तो ये एक किडनी है, इसको बहुत ध्यान से देखें, दोनों ही किडनीज जो है वो इकोजेनिक है और so the renal parenchyma is definitely echogenic. So the amniotic fluid is 14. Okay, so these are the echogenic kidneys, right? And so they are not enlarged for the gestational age. Okay, but then these are definitely echogenic. and the amniotic fluid is also 14. Okay, so well, that is also well within the normal range. Okay, and meaning thereby that probably we made a note of this echogenic kidneys, right? And now what to do further? So probably we asked them to see us back, and the findings were same after 10 days, है ना? And I'll explain what we have done, but probably just look around that there are some values known as sodium chloride, osmolality, beta 2 microglobulin. Just make a note कि ये सब values available होती है और इनका कुछ parameter होती है. So the genetic etiology is this, that there were six genetic conditions different and six metabolic autosomal recessive conditions they can be responsible for these echogenic kidneys. Right, this is an entirely different new case which is not associated, but you see this couple is having these genetic mutations. So what we have seen in the last two slides is this, that this was a couple which had come with the baby with some congenital abnormalities and had a bad obstetric history. So we have done a carrier screening for them, and astonishingly we'll identify that both of them they are having pathogenic mutations. We are talking about pathogenic mutations, not variation of unknown significance in 8 genes. Could you beat that? सो मीनिंग देयर बाय कि इट इज ओनली बाय चांस कि 8 जीन्स डिफेक्टिव हैं, दोनों हस्बैंड एंड वाइफ में, कि कोई किसी के लिए कैरियर है तो कोई किसी के लिए कैरियर नहीं है. राइट, यू गेटिंग माय पॉइंट? तो वो एक एंटायरली, तो मीनिंग देयर बाय दैट आई वांट टू इंप्रेस अपॉन दैट प्रोबेबली इफ समबडी सेज दैट बॉस वी डोंट हैव एनीबडी in our family being affected, or we don't have any family history for genetic condition, it really doesn't work this way. So probably we need to do a career screening, and we really don't know what an individual or could be husband and wife or a father and mother could be a carrier for their genetic conditions, right? And then we have learned that there could be some ADPKD, ARPKD, nephronophthisis, MCKD, Zellweger, Meckel-Gruber, right? And then we can have some 8 metabolic syndromes, right? In which there could be some deposition of those metabolites, and therefore the prenatal, it could be like an echogenic kidneys, right? Okay, so, and so those are autosomal recessive, meaning thereby that doing the carrier screening for both the parents can definitely shed some light about the carrier status of the parents, as a matter of fact. Okay, and but what we did in this case is this, that we did the amniocentesis, right? Since the bladder was not that huge, bladder बहुत बड़ा नहीं था और हमारे पास इतनी स्पेस नहीं थी कि that probably we could have done a vesicocentesis. Vesicocentesis is a sub part of doing an amniocentesis, in which we put the needle into the fetal bladder and take out the fetal urine. And but we did the amniocentesis. एमनिसेंटेसिस में हमने ये देखा है कि हमारे पास एमनियोटिक फ्लूइड के लिए सोडियम क्लोराइड, ऑस्मोलैरिटी और बीटा 2 माइक्रोग्लोबुलिन्स के लिए नोमोग्राम्स जेस्टेशनल एज के अकॉर्डिंग अवेलेबल है, right? So meaning thereby that the kidneys they need to concentrate and therefore they need to absorb all these things. So what we've identified is this, कि जो क्लोराइड है और जो सोडियम है, जो बीटा 2 माइक्रोग्लोबुलिन है और जो ऑस्मोलैरिटीज है, ऑल द 4 parameters on the amniotic fluid biochemistry were abnormal. So establishing the very fact that the renal functions are abnormal to the fetus, right? So this is the first and foremost, and the results can be available within something around 4 days. And this NGS or the exomes, the report can be available within 21 to 23 days. So these are different sort of an, or this they could be an added on investigation that probably we can do an amniotic fluid so as to identify what genetically is happening to the baby, but functionally what we've identified is this, कि सोडियम की जो वैल्यू है, क्लोराइड की जो वैल्यू है, ऑस्मोलैरिटी की जो वैल्यू है और जो बीटा 2 माइक्रोग्लोबुलिन की जो वैल्यू है, उससे वो 2.5 टाइम्स ज़्यादा था. दैट आई हैव एक्सप्लेन्ड इन द डिटेल इन द स्लाइड्स ऑल्सो, कि उनके हमारे पास नोमोग्राम्स अवेलेबल है, उससे ज़्यादा वो था. सो दैट गिव्स अस द फर्स्ट इंडिकेशन that probably there could be some issues with the kidneys and the kidneys are failing, and they are not up to the mark, right? And since it is happening to both the kidneys, and we have what we have done is this, that we have done an amniocentesis. So meaning thereby that you can imagine the urine which got diluted, the 40 ml का जो urine है which gets diluted in something around 650 or 700 amniotic fluid. So what would have been the concentration if we would have done the vesicosynthesis, or probably if we have had the fetal urine for this examination? You getting my point? So meaning thereby that doing the amniotic fluid biochemistry can definitely give the first indication and the first sort of an shedding the light so as to see the renal functioning or the renal RFT, renal functioning tests for the fetal kidney. राइट बीटा टू माइक्रोग्लोबुलिन का ऐसा है कि हम ये समझते हैं कि 5 to 6 मिलीग्राम पर डेसीलीटर से नीचे ही होना चाहिए एंड व्हाट वी गॉट वाज 11.1 right. So that is also there are different literatures and nomograms available in the literature which suggests that it is beyond that particular point, and so that might help us in objectifying and probably making an objective diagnosis about the renal functioning of that kidneys. Right. Thank you very much for your question, listener.